Hello everyone, my name is V, and today I'm going to discuss a cardiovascular disease, aortic dissection. So first, this is a typical patient presentation. A 65-year-old man comes to his physician to complain about his sudden chest pain. He describes it as a sharp pain that radiates to the back. It feels like my chest is ripping off, he said. And he also feels a numbness and tingling in his limbs. His physician notes that he is very hypersensitive and overweight. His mom, who passed away 8 years ago, had a history of Marfan syndrome. And later on, he is diagnosed with aortic dissection. So here's the etiology of aortic dissection. But first, let's have some quick anatomy review. As you know, aorta is the largest arteries within the body, and it composed of 3 layers. The innermost layer is called tunica intima. It composed of endothelial cells. The second layer is called tunica media. It mostly have smooth muscle cells and elastic fibers for the elasticity of the aorta. And the last layer is called tunica adventitia. It has a lot of collagen fibers, act as a supportive element for the aorta. And aortic dissection is when there's a tear on the innermost layer of aorta, which is the tunica intima, and this tear can separate the aortic wall. The intimal tear can be due to chronic hypertension, aneurysm, or connective tissue disorders. And later on, we're gonna discuss how these factors contribute to the aortic dissection. As you can see right here, there's 2 types of aortic dissection. Type A is when the dissection involves ascending aorta and or aortic arch. Meanwhile, type B only involves descending aorta, and there's no involvement of ascending aorta at all. So here's some background of the aortic dissection. In the United States, there are 3 cases every 10,000 individuals per year. This is a very fatal disease that it causes about 30,000 deaths each year. Study actually show that there's a slightly higher incidence in winter months, but the cause is unknown. The survival rate at 5 years was estimated as 60 to 66%. As you can see on your right here, as the years increase, the survival rate decrease. So here are some risk factors of aortic dissection. Patients with aortic dissections are mostly male at the age of 60 to 80 years old. The greatest risk factor of aortic dissection is hypertension. As I mentioned in etiology, the high pressure blood flow within the aorta can stress the arterial wall and eventually make a tear on the tunica intima of the aorta. Another risk factor is inherited connective tissue diseases. Like Marfan syndrome is a change in gene that encodes the major components of connective tissue in the tunica media, including fibrillin and elastic fibers. Meanwhile, Ehlers-Danlos syndrome, EDS, causes the hyperextensibility and tissue fragility. Patients who have inherited connective tissue diseases has a very weak arterial wall, so that increases the chance of elastic disruption and degeneration of aortic wall. And when we discuss about the pathophysiology of aortic dissection, you will understand why elastic disruption and degeneration of aortic wall contribute to the vessel dissection. Another risk factor is aneurysm. This is a bulging of a vessel wall due to the weakness in the wall. The last risk factor is the lifestyle factors. This is very important because imagine if someone has very poor diet, they consume high cholesterol food or like fast food every day, they smoke, they just don't do any exercise, that can lead to a higher chance of getting atherosclerosis. And as you know about atherosclerosis, is increased the resistance within the blood vessels, so that the heart will have to use a greater force to pump the blood. So that can lead to hypertension. And again, hypertension is the greatest risk of aortic dissection. Here's the pathophysiology of aortic dissection. As I mentioned, aorta is the largest artery in your body that receives the high pressure blood from the heart and send it to the rest of the body. So it experiences shear stress every minute. At some point, the aortic wall gets weak, especially with those who have connective tissue diseases. As we mentioned in the previous slide, they already have a weak aortic wall that cannot handle this constant mechanical trauma. So as the high pressure blood keep pressing on the aortic wall, it can make a tear on the innermost layer of the aorta, which is the tunica intima right here. As you can see, there's a tear right here. A tear is like open a new pathway for the blood. So the high pressure blood will rush through this tear, go into the tunica media, and eventually cause a split within the media layer of the aorta. So when the high pressure blood keeps flowing into the tunica media, it can make the split longer and bigger. And it can also inflame the aortic wall, leading to the death of vascular smooth muscle cells, which are used for contraction of aorta. So the aorta cannot contract that well to send the blood to the rest of the body anymore. Additionally, the partition of tunica media can fragment the elastic fibers. As we mentioned earlier, elastic fibers contribute to the elasticity of aorta. So if elastic disruption happens, it can reduce the elasticity of aorta, make it less resilient. Eventually, the high pressure blood within the tunica media can separate the media layer from the intima layer, which is known as vessel dissection. This is a quick summary of what we just talked about. As you can see right here, we have a high pressure blood keep pressing on the aortic wall. That can cause a tear on the tunica intima of the aorta. And that tear opens a new pathway for the blood to flow into the tunica media. As more and more blood flows into this space, it can completely separate the intima from media of the aorta. Additionally, the accumulation of blood between these two layers is called false lumen. So we have true lumen right here and false lumen right here. And true lumen tends to be smaller than false lumen. In some serious cases, the false lumen can escape into nearby region when the aortic wall is disrupted. With that idea, here's some possible complications of the aortic dissection. The most fatal one is the cardiac tamponade, which is the dissection leads to a leakage of blood in pericardium. As I mentioned in the previous slide, the false lumen can escape into nearby regions, such as the pericardium. The pericardium is a membrane surrounds the heart that holds the heart in place and helps it work normally. So if there's an accumulation of blood within this membrane, the heart cannot pump blood that sufficiently anymore. That can lead to heart failure, which is very fatal because it cannot send the oxygenated blood to the aortic organs. Another possible complication is the false lumen keep pressing on the aortic valve. As you see right here, over time, there's a disruption of the aortic valve that it cannot close normally. And that makes the blood flows back from the aorta into the left ventricle. And it is called aortic regurgitation. Here are some of the symptoms that a patient with aortic dissection might experience. The most common one is the sharp onset chest or back pain. Like the man in the beginning, most patients complain about the extreme chest pain that make them feel like their chest is ripping up. And for the type B aortic dissection, involves the descending aorta, which is the abdominal aorta. The patient may experience the abdominal pain. And if you remember, the false lumen tends to be bigger than the true lumen, so it can compress on the true lumen, which stops the blood flow to the peripheral vessels, leading to pulse deficit. And if your nearby organs, such as your kidneys, doesn't receive enough oxygenated blood to function, it can lead to organs ischemia. The same mechanism for your brain. If your brain doesn't receive enough oxygenated blood to function, it can lead to neurologic deficits like hoarseness or loss of consciousness. In patients with cardiac tamponade, the heart cannot pump blood sufficiently, so that can affect the gas exchange within the lungs due to the poor blood circulation. Here are some methods that can be used to detect aortic dissection. Chest X-ray is used to detect the widening of mediastinum or abnormal aortic outline. The false lumen might make your aorta look bigger. Multi-detector CT, MDCT, has a very high sensitivity and specificity to give us an early image of the dissection or any presence of associated complications like cardiotamponade or false lumen. Another method is genitophageal echocardiography, TEE. This is mostly used in hemodynamically unstable patients. The physician will insert a tube with transducer into the esophagus, and that will give us an image of most segments of the aorta. However, compared to the MDCT, it doesn't provide clear images of descending aorta. The last one is MR imaging or arteriograms. It provides the information about aortic function like blood volume, ejection fraction, valve function, or aortic branching vessels. However, it takes a long time to take the MRI result, so it's only best used for long-term follow-up of aortic dissection, not in emergent cases. This is the genitophageal echocardiography, and it allows the physicians to detect the presence of false lumen. If you look right here, we have the true lumen, and here's the tear that lead to the false lumen. And again, the false lumen looks way bigger than the true lumen. And if you notice, it doesn't give you a really big image of the descending aorta. It's just a small segment of the aorta. On the other hand, this guy multi-detector CT right here seems to do a way better job on giving us a big view on the aorta. And if you look right here, we have the true lumen, and above is the false lumen that compressing on the true lumen. And MTCT provides us a more precise images of the aortic vessels and its preparation. As you can see right here is the descending aorta, and here's the ascending aorta. There's different treatment for each type of aortic dissection. Type A tends to be more fatal than type B. 80% of type A patients are treated surgically to prevent aortic rupture and to prevent other complications as well, like cardiac tamponade. Meanwhile, uncomplicated cases in type B can be initially controlled with medications, like antihypertensive agents. However, complicated cases need surgical treatment just like type A patients do. There are two specific treatments of aortic dissection, non-surgical and surgical. Like I said, for uncomplicated cases, physicians may use antihypertensive agents like beta blockers to lower the blood pressure, and pain relief like morphine for the chest pain. They can also use vasodilators and AC inhibitors like nitroprusside or hydralazine for the dilation of blood vessels. For surgical treatments, there are thoracic endovascular aortic impair or traditional open heart surgery. And later we're going to go deeply discussing the difference between these two. The first thing that physicians may want to do is lower the blood pressure, because if the high pressure blood keep flowing in the aorta, it can make the tear or the split become worse. That is when they use antihypertensive agents like beta blockers. The mechanism of beta blockers is to bind on these epinephrine receptors, stopping the hormone epinephrine from binding on its receptor, and it can lower the heart rate and the pressure of the aortic wall. Physicians can also use pain relief like morphine for chest pain, and this medication will depress the release of transmitters associated with the feeling of pain. FYI, the inability to feel pain is called analgesia. As I said earlier, false lumen compressing on true lumen can lead to organ ischemia. So we want our aortic vessel to dilate to increase the blood flow to these organs. This is when physicians may use vasodilators. There's different type of vasodilators, but the most common one is calcium channel blockers. As we learn in physiology, calcium plays an important role in the contraction of smooth muscle cells. So the vasodilators will block the calcium channels, decreasing the amount of calcium going into the cell. When there's a decreased amount of calcium, the aortic vessel will start to dilate. The last medication is AC inhibitors. As you know, ACE is angiotensin converting enzyme that converts the angiotensin 1 into the active vasoconstrictor angiotensin 2. And ACE inhibitors will stop this production of angiotensin 2 that can help the vessel to relax and increase the blood flow. Here's the surgical treatment. The most common one is thoracic endovascular aortic repair. It's repairing the aorta with a synthetic graft, and the Dacron graft is what the surgeons usually use. Technically, they're gonna make an incision in the groin area or your arm, and they're gonna insert a catheter with a stent graft at the end of it into your aorta. And when the catheter meets the damaged area, they will fastening the stent graft in the dissection. Another method is traditional open heart surgery, they're not gonna use catheter in this method, but they're gonna make a direct incision in the chest or your abdomen, depend on what type of aortic dissection that you have. And the same way, they're gonna use the synthesis graft to replace the damaged area of the aorta. And they will also make replacement of damaged aortic valve if needed. This is what thoracic endovascular aortic repair look like. As you see right here, they insert a catheter with a stent graft at the end into the true lumen. And when the catheter meets the tear on the intima layer, they're gonna fasten it to block the tear and to block the false lumen flow as well. This picture doesn't show, but if there's another tear on the intima layer, this stent graft will expand and to block the flow of false lumen into this space as well. After operation, the physicians will make some checkup for their patients to make sure that the surgery goes well. And they might use MRI or arteriograms to check the stability of aorta and whether the dissection is growing or worsening. They can also use echocardiograms to check the heart rhythm and the blood flow through the heart for patients with reconstructed valves, because they want to make sure that the valves are working normally. And the most important thing is long-term antihypertensive treatment. As I said again, aorta receive the high pressure blood from the heart. So with patients that has aortic dissection, we want to lower their blood pressure even under 120/80, which is a normal measurement, to prevent the reconstructed areas from tearing apart again. And it's a recommendation that patients should check up 3 to 9 months after onset. That's everything I have for you guys today. I hope you enjoy aortic dissection. And here's my references. Thank you for listening.